Okay, hi everybody. Today we're going to bring you a presentation for MRI, specifically MRI of the head. My name is Christine Eckenrod, and this webinar is brought to you by Medical Professionals, a CE company. I'm a consultant for medical professionals, and I'm happy to collaborate with them on this free CE credit to help introduce you to medical professionals' products and services. I have been an MRI tech for 20 years. I graduated from radiography school way back in 1987. I became a CT tech in 1983. I cross-trained in MRI in 2005 and then passed my MRI boards in 2010. Currently, I am assistant professor and program director for radiography at Penn College of Technology, where I teach Introduction to Medical Imaging, Radiation Protection, and Biology, professional seminar, and first-year experience courses. I hope that you find this presentation enjoyable and that we all learn something. As a reminder, if you have any questions for me during the presentation, please enter them into the chat feature and we'll review those questions during the breaks. Upon completion of the webinar, attendees should be able to understand and utilize different MRI imaging planes for head imaging, identify the most common MRI protocols and sequences used in MRI of the head, implement and plan for MRA and MRV techniques for vascular enhancement, optimize MRI planning and parameters for high quality imaging. Here we see the outline for the presentation so that you can see what we will be covering. In section 1, we will focus on imaging planes and scan planning. In section 2, we will take a dive into imaging parameters and help to optimize our imaging and the sequences performed for various exams. Imaging different structures in the head using MRI requires specific protocols tailored for each area's anatomical structures and to various pathological processes. These protocols include choosing the correct imaging plane to show the desired details. It's critical to know exactly which planes will show which structures best. We will explore the imaging planes used for MRI of the brain, internal auditory canals, orbits, sinuses, and for MRA and MRV imaging. If you are familiar with CT or MRI, you likely recall the 3 planes of the body: axial or transverse, coronal, and sagittal. Any of these 3 can be chosen to maximize the visualization of specific anatomical features and potential pathologies. Selecting the appropriate plane ensures a comprehensive evaluation of the respective structures. The selection of a sequence such as T1, T2, flare, or time of flight will be discussed later in the presentation. As a quick review, here we see the 3 imaging planes. First is this, first one is the transverse, and this is going to divide the body into sections from head to foot. The next one we have is the coronal. It divides the body into sections from front to back or back to front. And it gives us what might look like an AP or a PA projection, if you're familiar or if you still remember from radiography. And the last one is going to be the sagittal. It divides the body into sections from left to right. And it looks like a lateral, so to speak. All of these planes are axial. The definition of axial means a slice through any plane of the anatomy, but we most often refer to transverse, or this first one, the transverse slices, as being our axials. So you may hear me, or you will hear me probably, refer to it as axial transverse fairly often, just for, to make it clear what I mean by axial. In MRI, and understanding the appropriate imaging planes and planning field for the field of view, etc., is crucial for obtaining high quality images that provide the details for accurate diagnosis. Okay. So what do these, I'm going to go back one slide. Yeah. All right, so I'm going to go back to this slide real quick. I have some more for this one. As I mentioned, each of these planes is essential for providing an overview of the brain's structure and can reveal specific details depending on the orientation. The axial plane is the most used imaging plane in MRI. Axial images provide a view of the brain from top to bottom, so from head to foot, allowing for detailed examination of structures like the basal ganglia, the thalamus, the brainstem, the cerebellum. Pathologies such as tumors, infarctions, hemorrhages, and pathologies of white matter can be accurately assessed in this plane. The coronal plane divides the brain from front to back. It provides a view, if you think about it, from ear to ear. So we should be able to see from one ear to the other ear. Coronal images are particularly useful for evaluating structures along the midline, such as the corpus callosum, the fornix, and the septum pelliculum. Additionally, this plane allows for the assessment of the lateral ventricles, the hippocampi, and cortical structures. Coronal images are valuable in diagnosing conditions like hydrocephalus, temporal lobe epilepsy, and certain developmental abnormalities. Sagittal plane images provide a lateral view of the brain, dividing it into left and right halves. This plane helps assess midline structures such as the false cerebri, the pineal gland, and the interhemispheric fissure. Sagittal images also allow the evaluation of the cerebral vermis and lateral cerebellar hemispheres. Pathologies such as midline tumors, Chiari malformations, and abnormalities of the corpus callosum are well visualized in this plane. Now we'll move on. Sorry about that. All right, in MRI of the internal auditory canal, or IACs, the imaging planes used most frequently are axial transverse and coronal. The axial transverse plane is crucial for evaluating the structures within the IAC itself. It provides a cross-sectional view of the IAC, allowing for detailed assessment of the cochlear and vestibular nerves and the facial nerve as they transverse through the canal. Additionally, the axial plane helps in detecting pathologies such as vestibular schwannomas, otherwise known as acoustic neuromas, also meningiomas, and other lesions affecting the nerves and adjacent structures within the canal. The coronal plane in IAC imaging is essential for visualization of the relationship between the IAC and the adjacent structures. This includes the cochlea, the vestibule, and semicircular canals within the inner ear. It provides a view from front to back, allowing the assessment of the extent of any lesion that might be detected in the axial transverse plane and their proximity to vital structures. The coronal plane is particularly useful in evaluating the involvement of the cochlear nerve and the facial nerve within the canal by tumors or other pathologies. While not as commonly used as axial or coronal images, the oblique sagittal plane is sometimes employed in MRI of the IACs to provide a longitudinal view of the internal auditory canal. This plane can help in the assessing of the length of the canal, the course of the nerves, and any abnormalities along their path. It may be especially useful in cases where the extent of a lesion or the involvement of adjacent structures needs to be precisely evaluated. That plane would be done, rather than doing a straight sagittal, if you can, hopefully you can see my arrow. Straight sagittal would be along this plane. We do an oblique this way. So the angle of the oblique would be like that, okay? So hopefully you can see my arrow on the screen. Hopefully you can see that. All right, let's move on. All right, commonly utilized imaging planes during orbital MRI are the axial transverse, coronal and sagittal planes. I feel like I'm dictating now. All right, the axial plane provides a cross-sectional view of the orbit from front to back, and it's essential for evaluating the anatomy of the globe or the eyeball. The extraocular muscles, the optic nerve, the lacrimal gland, and surrounding soft tissues. The axial plane is particularly important for detecting and characterizing various orbital pathologies, including orbital masses such as tumors or cysts, inflammatory conditions such as orbital cellulitis, or thyroid eye disease, vascular abnormalities, and traumatic injuries such as orbital fractures or hemorrhages. Additionally, the axial plane allows assessment of the relationship between the orbital structures and can aid in determining the extent of involvement of adjacent structures in pathology. That's this one right here. This is your axial transverse. The coronal provides a view of the orbit from side to side, perpendicular to the axial plane. It is useful for evaluating the superior inferior relationships of orbital structures and can help in detecting lesions involving the superior or inferior aspects of the orbit. The coronal plane is important for assessing the lacrimal apparatus, including the lacrimal gland, lacrimal sac, and the nasolacrimal duct. It's also helpful for evaluating the relationships between the optic nerve and surrounding structures, as well as detecting lesions that may extend into the orbit from adjacent structures such as the paranasal sinuses. The sagittal plane provides a lateral view of the orbit, dividing it into medial and lateral halves. It is useful for evaluating structures such as the medial and lateral rectus muscle, as well as the relationship between the globe and the optic nerve. An oblique sagittal is used with the orbits because it's important for detecting lesions involving the posterior aspect of the orbit, including the affecting pathology to the optic nerve sheath or extending into the orbital apex. So if you look at, here's our sagittal, we can see the globe here, we can see the muscles above and below, and then we can see the optic nerve travels right through the middle here. In order to get that oblique sagittal, we would angle our slices to the path of the optic nerve. Okay, so we would angle right along this way to give us that oblique sagittal. Okay, all right. For MRI of the sinuses, the most common planes are coronal, transverse, and sagittal. The coronal plane is the primary imaging plane used in MRI of the sinuses. It provides a view of the sinuses from front to back, allowing for a detailed assessment of the paranasal sinuses, including maxillary, ethmoid, frontal, and sphenoid sinuses. The coronal plane is particularly important for evaluating sinus mucosa thickening, sinus opacification, fluid levels within the sinuses, and the presence of polyps or other mass lesions in the sinus cavity. Opacification of the sinuses indicates sinusitis, while fluid levels within the sinuses suggest acute sinusitis or mucoceles. The coronal plane allows for the assessment of anatomical variations such as pneumatization patterns and septal deviations, which can impact sinus drainage and predispose our patients to sinus disease. The transverse plane can be complementary and provide information about MRI of the sinuses, as it offers a cross-sectional view of the sinuses perpendicular to the coronal plane. It can help in further characterizing lesions detected in the coronal plane. In particular, the transverse plane is useful in assessing the extent of disease involvement in the orbital and skull-based regions, as well as evaluating the relationship between sinus disease and adjacent structures, such as the orbit, optic nerves, and cranial nerves. This plane is also helpful in detecting intracranial complications from sinusitis, such as abscess or meningitis. The sagittal plane is used less frequently in MRI of the sinuses compared to the coronal and transverse planes. However, it can be employed to provide additional anatomic information, particularly regarding the anterior and posterior relationships of the sinuses and their proximity to adjacent structures. The sagittal plane may be useful in cases where there is suspected pathology involving the anterior or posterior ethmoid sinuses, or for evaluating the extent of disease involvement along the skull base. Magnetic resonance imaging, magnetic resonance angiography, or MRA, and magnetic resonance venography, or MRV, of the brain are done using a scanning technique called time of flight, or TOF. Time of flight techniques are commonly used in both two-dimensional and three-dimensional imaging, and they help us to evaluate blood flow. Three-dimensional time of flight, MRA or MRV, is typically acquired in a three-dimensional space and can be reconstructed in multiple imaging planes, including axial, coronal, and sagittal planes. Time of flight imaging provides high-resolution images of the cerebral arteries in MRA and veins in MRV without the need for contrast agents. This technique utilizes the flow-related enhancement of blood vessels. The multiplanar capability of time-of-flight techniques allows for comprehensive evaluation of the cerebral vasculature in all three dimensions, facilitating the detection of arterial stenosis, aneurysms, arteriovenous malformations, venous sinus thrombosis, and other vascular abnormalities. Similar to three-dimensional time of flight, the two-dimensional time of flight sequences can also be acquired in multiple imaging planes, including axial, coronal, and sagittal. However, two-dimensional time of flight sequences provide thinner slices compared to two-dimensional time of flight, which may be advantageous for better visualization of small vessels or delineation of vascular anatomy in specific regions of interest. 2D time of flight, MRA and MRV, is particularly useful for detailed evaluation of the intracranial arteries and veins, especially in cases where high spatial resolution is required. All right, our next part of section 1, before we take a little break, is going to talk a little bit more about planning. So the planning techniques in MRA of the head. So now that we have learned about the most commonly used planes in MRI for each of the anatomical structures of the head, we will be discussing how to plan imaging in these fields, in the fields of view, sorry. Each of the anatomical structures we discussed, whether it's the brain, IAC, orbit, or sinuses, has specific orientations that optimize the visualization of their anatomy and any potential pathologies. For example, the transverse plane is often preferred for imaging of the whole brain and for the IACs, due to its ability to provide detailed cross-sectional views, while the coronal plane is essential for assessing structures like the orbits and paranasal sinuses, offering a comprehensive front-to-back perspective. Understanding the appropriate imaging planes and planning the field of view accordingly is crucial for obtaining high-quality images that provide detailed and accurate diagnostic information, ultimately guiding clinical decision-making by the radiologist, the ordering physician, and optimizing patient management. To plan transverse axial slices on the sagittal plane, the field of view block should be aligned parallel. I'm sorry, I need to back up for a second. I feel like some of the slides are out of order. I apologize from whenever I rehearsed it. Okay, so we're going to come back to this image. So to plan transverse axial slices, we use the sagittal plane. If you notice, the field of view block is positioned so that the lines are parallel to the corpus callosum. This ensures comprehensive coverage of the brain structures. Notice that on the sagittal localizer, the slices are slightly angled. So if you notice on this sagittal localizer, you can see a line that goes through that's showing that we are parallel to the corpus callosum. Okay, so there's a slight angle to it. Verification of the planning block and in the other two planes by reviewing the coronal and axial localizers is also important because we want to make sure that our field of view encompasses the entire brain when we are imaging the brain. Also, on the coronal, this patient is straight, but if the patient was tilted at all, we would be able to tell that, and we could angle our slices to tilt with the patient's head as well. Okay. So on the coronal localizer, we need to ensure that the head is straight, and if not, angle the block to maintain perpendicular alignment to the line between the third ventricle and the brain stem. The axial slices should be strategically positioned to cover the entire brain from the vertex, which is the top of the skull, down through the foramen magnum. This facilitates a detailed examination of the brain anatomy and pathology across its entirety. Basically, the axial slices should be slightly oblique according to the long axis of the corpus callosum, as previously discussed. To plan the sagittal slices, we are going to plan on the axial and coronal localizers. We want to align the planning block parallel to the brain's midline. So we can easily, on the coronal and on the sagittal, or I'm sorry, on the transverse, we can easily find we can easily find the midline, and we want to angle the slices so that we are going straight parallel to the midline. We want to ensure comprehensive coverage of all the cerebral structures. Verifying the planning block in the other two planes is important. In the coronal plane, the planning block should be angled to be parallel to the line along the brain's midline and the fourth ventricle. This alignment facilitates optimal imaging of the brain's lateral aspects. The operator should ensure the adequate number of slices to encompass the entire brain from one temporal lobe to the other. So we want to have slices from the edge of one temporal lobe to the edge of the other. This one has probably 2 more slices than we might need. Again, note on the localizers that the lines on the axial and coronal are slightly turned in order to maintain that proper alignment to the midline and fourth ventricle. We check the sagittal localizer to make sure that our field of view is large enough that we are encompassing the entire brain. To plan our coronal slices, we use the axial and sagittal planes. We align the planning block perpendicular to the anterior commissure, posterior commissure, or in other words, the AC to PC line, ensuring complete coverage of the cerebral structures. We verify the planning block in the other two planes to ensure planning accuracy. So typically, if we were to draw a line from this first slice to the back slice, that line should be the same angle as the angle we had on our axial slices for the first sequences. When I was first learning, we would actually put our axial slices up and then put the coronal slices on top of them so that we could make sure that they were 90 degrees to one another, and then remove the axial slices. So not to confuse you, but that's a different way, if you're just learning, it's a different way to make sure you're getting the correct angle. In the sagittal plane, the planning block should be angled to be parallel to the line along the brain's midline and fourth ventricle. This alignment will allow for optimal imaging of the brain's lateral aspects. Okay. So again, looking at your localizers, note that on the sagittal localizer, the slight angle, and on the axial localizer, a slight angle that's used to ensure that the images will be demonstrated properly. Check your coronal localizer to make sure that the field of view is large enough to encompass the entire brain. You will note that once you master an MRI of the brain, it's pretty easy to move on to any of the other types of imaging of an MRI of the brain. Here we're planning the coronal plane for IAC imaging. Planning the coronal plane for the IACs is the same as the brain, only we will be performing our slices, thinner slices, to allow clearer visualization of the IACs and the delicate structures within. You may recall that the thinner the slices you have, the better the spatial resolution. So these thinner slices are going to allow us to be able to see these very small structures well. The transverse plane is planned using the coronal plane, where we make sure that our field of view coverage starts just above the cranial, the canal, and ends just below it. The thinner slices used are going to be about 0.5 millimeters up to about 2 millimeters in thickness. To save time on the scan, we only scan through the area of interest. So for example, if we tried to do 0.5 millimeter slices or 2 millimeter slices through the entire brain, that would take a significant amount of time. MRIs are long enough, we don't need to make them any longer. Okay, so we are covering, here we have if you could see behind the lines, you can see the cochlea right here. You can see part of it over here. So we only need to go from the very bottom of the brain to below the canal, okay, in order to see the images. When planning this scan, because we're not including all of the anatomical structures of the brain, make sure to check the phase encoding direction, also known as phase direction or oversampling direction, and fold over direction. There's several different names depending on the manufacturer. Images of the IACs are usually acquired in the right to left phase encoding direction to avoid any fold over artifacts. Be sure to widen the field of view from on the sides to include the external ear completely so that it doesn't fold over. So for instance, if you see the patient's earlobe down here, if our field of view didn't encompass that, the ears could fold over into the image. So we want to make sure that our field of view is larger than the maximum distance from side to side for that particular patient. Because of the small fine details within the orbit, precise alignment and coverage are crucial in order to capture all of the orbital anatomy as well. So when planning the axial slices, the planning block should be positioned parallel to the line that connects the supraorbital rims or the infraorbital meatal line. Referring to the sagittal localizer, you can see the angle at which the block should be positioned. Be sure the block extends from the infraorbital rim to the superior orbital roof, covering the entire vertical extent of the orbit. Refer to the coronal localizer, and you will see that both orbits are covered. Be careful when planning on the sagittal localizer. You will want to pick a slice that is only showing one orbit so that you can ensure proper coverage and angles. Okay. Excuse me. The phase direction of the axial images of the orbit is usually right to left direction. Be sure to expand your field of view in the right to left direction to include all of the anatomy and avoid wrap or aliasing artifacts. Also, check the alignment of the block to ensure it includes the optic nerves, extraocular muscles, globes, and retrobulbar space. One tip that you might have due to eye motion is to cover the patient's eyes with a cloth so that they're not moving their eyes around. If it's still hard to control, you can change your phase encoding direction so that you have another set of pictures with the motion going in a different direction. I'm not sure why patients tend to want to look around and move their eyes when you're scanning their orbits for some reason. All right, the sagittal plane offers a unique perspective of the anatomical structures of the orbit, including the eye, the optic nerve, extraocular muscles, and the adjacent sinuses. This plane is best for assessing the relationship and depth of the structures. The sagittal plane should be angled, and I showed you a few slides ago what is meant by this. It should be angled so that it is aligned along the optic nerve and planned on the axial transverse slices. You can see that the axial localizer, you can see on the axial localizer the angle that we should be using. The field of view should cover the globe and the optic chiasm, which sits posterior to the apex of the orbit. So the apex of the orbit is going to be about here. Optic chiasm is going to be in this area. So we need to at least cover that area. This is important when diagnosing optic neuritis, optic nerve gliomas, and compressed lesions such as tumors or inflammation affecting the optic nerve. Coronal planning is very important for MRI sinuses. For these slice positions, the planning block perpendicular to the axial plane slices covering the entire extent of the orbits from front to back is important. Ensure that the block extends from the anterior aspect of the globe to the posterior part of the orbit, including the optic chiasm. Using the coronal localizer, verify that the planning block covers both orbits entirely. The phase direction and the coronal plane of the orbit is anterior to posterior to make sure to extend the field of view to cover the anatomy and avoid aliasing artifacts. And I apologize, my slide said coronal planning for the MRI sinuses, but we're still talking about orbits, so I apologize for that. It is also common to place a saturation band to cover the posterior anatomy of the head to avoid having to increase the field of view. The saturation band will help to avoid unnecessary flow artifacts and help to reduce wrap artifact or aliasing. Now let's move on to the sinuses. Setting up a scan for an MRI of the sinuses is much the same as it is for the brain. The orientations do not change. The goal is to create more highly detailed images. Therefore, we require smaller slice thicknesses and a reduced field of view to include just the area of the sinuses. Both of these things will give us higher detail. For this examination, we want to ensure the block extends from the floor of the maxillary sinuses, so down by the upper mandible, to above the frontal sinuses, covering the entire vertical extent of the sinuses. We can use the sagittal localizer to verify that the planning block includes the maxillary, ethmoid, sphenoid, and frontal sinuses. It's easy to see all four of those on your sagittal. Because we are reducing the field of view and to include only the sinuses, or maybe just a little bit beyond the sinuses, we need to check the phase direction in all planes to avoid aliasing artifacts. Okay, so here we're going to go through the steps, including the planning and the field of view for MRA, specifically focusing on the circle of Willis and the cerebral arteries. We use the axial localizer and start by positioning the planning block parallel to the anterior commissure, posterior commissure line. This line runs horizontally through the brain, and it is an essential landmark for standard brain imaging. Next, make sure the block extends from the foramen magnum to the top of the brain to cover the entire circle of Willis and major cerebral arteries. Now we want to verify that the planning block is in the axial plane, ensuring that it covers the major arteries, which include the internal carotid arteries, anterior cerebral arteries, middle cerebral arteries, and posterior cerebral arteries. For proper coverage, check that the block extends from the anterior clinoid process to the posterior part of the brainstem, covering the entire anterior to posterior extent of the circle of Willis and related arteries. Planning should include thin slices, typically 1 to 2 millimeters, without gaps to achieve high resolution images of the vascular structures. A common field of view for an MRI of the brain is approximately 200 to 220 millimeters. Saturation bands help to avoid unnecessary flow artifacts. For example, when performing an MRA of the brain, we want to avoid venous flow. Therefore, a saturation band is placed above our slice block in order to prevent that. MRV imaging looks at the venous system of the brain. Common sequences for MRV include time of flight, phase contrast, and contrast enhanced. The field of view should cover the entire head to ensure the inclusion of all the venous system branches. Coverage should extend from the skull base to the vertex and from ear to ear. MRV is typically done in three-dimensional, so the image plane should be reconstructed in all three planes. Flow compensation techniques are used at times to reduce motion artifacts from blood flow. Since we're looking at the venous system for MRV, a saturation band could be placed below the skull because the blood is coming in that direction. We want to stop the flow of arterial blood into the images. All right, so that's going to bring us to section 2. And now we're going to talk a little bit more about parameters that are used in MRI imaging, okay? And they're telling me to go faster, so I'm sorry if I'm going too fast. I'm going to try to say what I need to say and not much more. All right, so MRI of the brain and other structures in the head involves various parameters that can be adjusted based on the patient's specific clinical conditions and the question that's being asked. The typical magnetic field strength found in clinical practice is about 1.5 Tesla to 3.0 Tesla scanners. There are higher Tesla scanners, but they're not in common practice. As we know, the field strength does play a role or plays an impact on how well our parameters work. Slice thickness is a parameter that is selected when prescribing MRI. Typically, slice thicknesses from anywhere to from 1 to 5 millimeters are used. Thinner slices are used when we need high resolution imaging. Thicker slices are used for faster scanning. The choice has to be made, whether you're doing it for speed or for slice thickness. And sometimes we have to weigh the benefits of doing both. With slice thicknesses, we also have a consideration for the slice gap, and that's the distance between the slices. For an adult brain, it's usually anywhere from 0 to 2 millimeters. A 0 millimeter gap is used for 3D imaging and when high resolution imaging is required. However, there's a trade-off with having no gap. The scans are going to take longer. The field of view determines the amount of anatomy that's included in the image. The brain imaging, it's about 220 to 250 millimeters, and that's going to be adequate for an adult. Because children have smaller head sizes, a smaller field of view could be used, so anywhere from 160 to 220 millimeters. When performing MRIs of some of the smaller sized head structures like the IACs, the orbits, sinuses, and pituitary gland, we find that the parameters are much different. For these small structures, we use thin slices anywhere from 0.5 millimeters to 1 millimeter, maybe even 2 millimeters, depending on the patient. The thinner slices provide high resolution. It's important to think about the size of the objects that you're imaging. Small objects require higher resolution. Small objects require thinner slices. For pediatric patients, maintaining a maximum slice thickness of 2 millimeters is recommended to ensure high resolution and detail in the smaller structures of their smaller sized brains. For smaller structures, we want a small field of view, anywhere from 100 millimeters to 160 millimeters. For pediatric patients, a field of view can be as small as 80 millimeters and maybe up to about 140 millimeters. We want to match their head sizes. The smaller field of view also helps to maintain high resolution for smaller images. The gap between the slices for the IACs, for example, is a minimum of 0 to 1 millimeter. Again, 0 millimeter gap is preferred for high resolution 3D imaging, but 0 millimeter gap requires more time. Always with the trade-offs. I'm sure if you work in MRI, I'm sure you know a lot about that. So let's talk about some of the different sequences that are done in MRI of various structures. Some commonly used sequences in MRI head imaging include T1, both pre and post contrast, T2, flare or fluid attenuation inversion recovery, ADCs, susceptibility weighted imaging, gradient echoes, perfusion weighted imaging, and spectroscopy. T1 weighted imaging is used for displaying high resolution anatomical details such as detecting fat and hemorrhage, and for post-contrast sequences. It is used to display anatomical details of the sinuses and nasal cavity and to assess both gray and white matter in the brain. Post-contrast enhancement for IACs, and particularly for the auditory nerves and structures of the inner ear, also use T1 weighting, as does sinus anatomy evaluation and soft tissue mass detection. All tissues have different T1 relaxation times, giving them different appearances on the MRI. For example, fat appears bright on T1 and water and CSF both appear dark on T1. Note the differences in the tissues as I scroll. So this, what I love about medical professionals is the interactivity that they have in some of their learning modules. So as you can see, as we scroll through there, the different tissues have different appearances on T1. Okay. T2 weighting highlights fluid containing structures and detects edema and other types of pathology. This includes fluid-filled structures like the cochlea and the vestibule. T2 weighting is also good for detecting tumors and other pathologies and can be used to evaluate abnormalities in the inner ear and the IAC. Okay. All tissues have a specific appearance on T2 weighting. Water and CSF are going to appear bright on T2. T2 weighting is often done with fat suppression in order to enhance fluid signal and to suppress the fat signal. This allows for better visualization of inflammatory processes. So I'll scroll through that as well. As you can see, different types of structures have different appearances on T2. Okay, so everything that you're seeing is bright, that's bright is CSF in the brain. Fluid attenuation inversion recovery, also known as FLAIR, is used to suppress fluid signals, such as the signal coming from CSF, in order to highlight lesions near the ventricles. FLAIR is also used for detecting multiple sclerosis plaques. So you can see on these sequences, and that is not, that is supposed to be a FLAIR, that is not a FLAIR, because that is a T2. All right. Next, we have diffusion weighted imaging, which is used to detect acute ischemic stroke and characterized by the cellularity of the lesions. So I can scroll through that so you can see what a DWI looks like. Okay. All right. ADC maps are used to complement DWI and help distinguish between cytotoxic and vasogenic edema. Susceptibility weighting imaging, or SWI, is important for detecting microhemorrhages, calcifications, and other venous structures. It's also used to evaluate trauma and vascular malformations. So I can scroll through that so you can see what some of the SWI slices look like. Okay. All right, so let's look at a few more sequences that are used in MRI of the head structures. Gradient echoes, this is spectroscopy. Let me see where the gradient echo is up here. No. Okay, gradient echoes are sensitive to blood products and mineralization. These sequences are used for detecting hemorrhages, small blood deposits, and cavernous malformations. Perfusion weighted imaging is used for measuring blood flow and volume of brain tissue. Spectroscopy, which is what we're seeing here, is used to analyze the chemical composition of brain tissue, thereby allowing the differentiation between tumor types and metabolic disorders. When contrast is used in MRI, it's most often used in post-contrast as a T1 weighted. I think we've talked about that, and oftentimes T1 with FATSAT. The contrast media changes the T1 weighting of certain types of tissue and allows for the enhancement of lesions and characterization of tumors and for the detection of inflammatory and infectious processes. 3D imaging is often run in some type of steady state pulse sequence. These sequences are used for high resolution imaging of the cranial nerves and inner ear structures. 3D sequences can provide detailed visualization of the cochlea, vestibular apparatus, and cranial nerves 7 and 8. Here we're looking at a pulse sequence used for MRA, the circle of Willis. First, we have the time of flight MRA. It's a non-contrast pulse sequence used to image the flow of blood in the arteries. By imaging the flow of blood, we are able to visualize the circle of Willis and detect stenosis or aneurysms. Contrast-enhanced MRA of the circle of Willis, on the other hand, requires the use of gadolinium. Here's an image of MRV, which is a specialized MRI technique used to look at the venous system. As mentioned, the MRV is typically done as a 2D time of flight or a 3D time of flight. Phase contrast MRV is a sequence that's used to quantify blood flow and visualize the venous system on different phase shifts. We also have the opportunity, we could do MRV as a gadolinium-based contrast injection, but again, we have the risk of the contrast injection that's possible. We also can do black blood imaging techniques such as T1 or T2 weighted sequences with flow suppression to look at the venous system. SWI is another sequence that provides high resolution imaging techniques that is sensitive to magnetic susceptibility differences between tissues. So let me see if these are on. Yep, they're not. Okay, on those slides. All right. Where was I? A less commonly used sequence is 4D MRV, which is also known as 4D flow MRV. It is an advanced imaging technique that combines three-dimensional spatial resolution with the fourth dimension of time. Okay. These are all special pulse sequences, not always performed on every MRA or MRV examination.